Thank you. I'm joined by Dr. Babi Whitaker, Chair of the IHN Seminar Committee and one of our IHN board members, and she will be helping me moderate the discussions, including the Q&A. And Dr. Babi Whitaker is a lead scientist in the Office of Biostatistics and Pharmacovigilance with the Center for Biologics Evaluation and Research at the US FDA. Over to you, Babi.
Thank you, Shruti. Welcome, everyone. We're very excited to present this this latest in our series of webinars. And so I would like to, I will introduce our first speaker, but before that, I'd like to let everyone know that we have identified a date and location for our next in-person IHN seminar, and that will be April 11th and 12th. In Athens, Greece. So I look forward to seeing you in person at that meeting, at that seminar meeting, and we really encourage everyone to attend. It's going to be a great meeting and a wonderful location. So without further ado, our first speaker is Dr. Christine Cserti-Gazdewich, and she is going to be speaking about transfusion reaction pathophysiology. What's riding under the hood of the archetypes? Dr. Cserti-Gazdewich is a transfusion medicine specialist and consultant hematologist trained in internal medicine and clinical hematology at University of Toronto and in transfusion medicine at Harvard. Based at the University Health Network for 17 years, she co-directs the blood transfusion laboratory serving an urban academic teaching hospital network at the University of Toronto, with outreach relationships to community and rural Ontario client sites. Her chief interests in practice leadership and research are immunohematology, hemovigilance, and complex constrained hemotherapy scenarios. So thank you so much, Dr. Cserti-Gazdewich, sorry to massacre your name, and welcome, and we really look forward to hearing your presentation. Thank you.
Thank you so much. I hope everyone is seeing the full version of my slide. Is that
Yes.
technically projecting okay? All right.
Yes.
Okay, thank you so much, everyone, for this great distinction. I have no industry conflicts, but I am part of a local team that's earned peer-reviewed funding to innovatively probe challenging cases in immunohematology and hemovigilance, though not with any patents in mind. I stayed behind from AABB last week and didn't contribute to that blockbuster JAMA issue on transfusion medicine that was simultaneously released with the meeting. I was saving myself for this seminar, the content of which is so near and dear to my heart. So the objectives, which I think were released in advance, speak to two key arcs. And the first one is dedicated to the acute reaction presentation archetypes, febriles, cardiorespiratory, and allergic. And very briefly, because I don't want to compete with the succeeding speakers, say a little bit about what the limits of our understanding are, at least in my own humble eyes, on the delayed immunologic reactions with the emphasis on hyperhaemolysis. So actually, I was a little daunted by the request to speak on the pathophysiology of reactions because it's sort of like asking for what is the unifying motif in cancer. But I do think that the pathophysiology question or approach is really strategic because it ties so meaningfully to training our powers and identification, advancing our testing capabilities, pinning down the factors that might be targets in management and prevention. And none of us will dispute that transfusions are high volume, high risk activities. That was sort of our lingo as we were adopting a new EMR, because people appreciated, even at the digitization level, that this can get risky. So thankfully, these two gradients or axes run counter to each other. So most of our reactions are minor or non-serious, but that's not to diminish the fact that some of these disturbances or annoyances are still really important to our patients. And in our experience here, about 20% of our disturbances are complex, meaning more than one thing is going wrong. And about 10 to 15% of our patients have some sort of a disposition escalation. And I would say that half of our reactions are non-minor and about 5 to 10% of them are severe. But most of our acute severe events are cardiopulmonary in nature. And just to distinguish, because this is sometimes a nuanced point with learners, that you can have, the highest lethality reaction, transfusion-associated graft versus host disease, very rare, with a near zero sum or cross product. And that's in contrast with the commonest cause of transfusion-related death. Again, though the case fatality rate is only 10%, the high volume occurrence of respiratory reactions together adds to at least dozens of fatalities as such, nation to nation. So my office is situated here at the Toronto General Hospital in Toronto, Ontario, Canada. And our University Health Network is a multi-site conglomerate of hospitals totaling about 1,000 beds. And we really try to push transfusion education. We've got a transfusion boot camp. When we run consent by our patients, we try to simplify it as much as possible. And my approach here is to speak to risk in 3 tiers. Things in threes are a lot more memorable, and each of these 3 tiers have 3 items within them. And so I speak to the things that occur in that 1 to 10% or higher frequency range, meaning the common minor events, non-serious fever, non-serious hives, and making antibodies to, what you pick on as, viewed as foreign in the transfusion stimulus. Tier 2, second letter of the alphabet, I call the 3 Bs. These are the things in the range of the 1 in 1,000 to 100,000 risk. And so these are breathing trouble, bacterial contamination, and a botched process. And breathing trouble arguably lifts up into the common realm if we acknowledge that TACO occurs a lot more often than, some hemovigilance schemes would indicate in passive surveillance numbers. The discussion kind of rounds out with some reassurances with the really rare 1 in a million or rarer risk. And that's, the odds of having a virally contaminated product, new or rare, not yet tested for bugs, and the concept of transfusion-associated graft versus host disease. And by mentioning that risk, we try to trigger our memories with the patient on whether or not they have special needs with respect to irradiating cellular products. And so our denominators of use at UHN are shown here. We dispense about 40,000 red cells per year and almost 10,000 platelets and over 12,000 plasma doses. We're a big apheresis center. But you can see that our per platelet reaction risk is significantly higher than our red cells, so about 10 to 20 per thousand versus 5 per thousand. And platelets therefore account for about half of all of our reactions, despite these denominator of use differences. And though the ratio of red cells to platelets is 4 to 1, it's very different when you look at the hem-onc patient, where it's almost at parity with 1 to 1.4. And our context here is universal pre-storage leukoreduction with quite a lot of pre-medication practice, especially in hem-onc. So altogether, we dispense almost 100,000 items per year if we throw the derivatives in there. In Canadian hospitals, we dispense, IVIG, albumin, the blood bank, rather than the pharmacy as the dispensary for these pharmaceuticalized plasma-derived purified protein products. And we serve about 7,000 unique recipients every year. And our numerator, our day-to-day reaction profile kind of looks like this. So we can have up to 4 to 5 transfusion reactions reported per day, and we average about 1 a day. I would say this year in 2023, we've been a lot more active than this. Last year, we went live with the new EMR, and so we had a bit of a reduction in our reporting in the midsummer. So again, our archetypes: febriles, blowing your top, superficial skin stuff, and then the deep visceral kind of central organ disturbances. When we looked at over a 4-year period, over 1,000 referrals, we found that, of course, fevers were the commonest reason for calling in a disturbance of concern for consultation, followed by allergic reactions. 70% of them were minor. And the minority, though not minor in import, were the cardiorespiratory reactions at almost 40%. And so you can stereotype by the contents and the mode of storage. And you could see here that platelets really are the winner for reactogenicity. You know, they're stored at room temperature. They're a dualistic product in the sense of having both plasma and cells. And if you stack up the risk of things like bacterial contamination, allergic reactions, FNHTRs, the risk of TGVHD, all of this stuff is dispensed within the window of cellular viability and trolley risk. Really nothing beats platelets as far as the concern goes. And I would say that low titer Group O whole blood, which we don't dispense here, is kind of in this mid zone of a refrigerated item that's also a duality with mixed, cells and plasma. So you can kind of begin to stereotype the sorts of risks that you expect based on the component that you're releasing. And the expected benefits of pharmaceuticalization, that is solvent detergent treated plasma and pathogen reduction with platelet additive solution in place of plasma, is this effect of bringing these risks down. And that's very important in the aforementioned high risk product that is platelets. So we have not yet adopted these changes. We just went live maybe a month and a half ago with solvent detergent treated plasma, which is now the majority of our stock. And next month, over the last week of November, we're going to go live with pathogen reduced PAS platelets. So we look forward to seeing what impact this is going to have on our reaction rates. And red cells, of course, remain unmodified. And so these changes have us ceasing irradiation for the modified platelets. Of course, we keep our irradiators for the red cells. And really the only thing to help further mitigate the risk of that standout residual product red cells is to try to reduce ordering there to bring the overall risk of transfusion events down. With these modified products coming in, we've been wondering if we ought to stop pre-medicating and if that should be part of our educational messaging as we prepare the hospital for these new products. We do have remote associate medical directorship relationship with rural and not just academic urban hospitals here in Toronto. And so altogether we serve quite a bit of Ontario. So about half of the Ontario population is served in these small and large hospitals that are in affiliation with us. And when we add in their reaction rates, they kind of press out to similar numbers within the range of 1 in 100 to 1 in 1,000. So about 1 in every 177 components with now pretty tight confidence intervals because we've got such big numbers added together. So one of our challenges in trying to figure out and analyze all of these signals coming in is the fact that we're on really disparate systems. And that's unfortunate because we don't have great interoperability quite yet. Our rural Ontario hospitals are on completely different technologies. And so hospitals in Ontario were allowed to evolve as corporations with their own independent hardware and software decisions. And due to silos and health, privacy, protection, and so forth, it's sometimes really hard to glean these signals. And people joke about this, that they're all of these, theoretical surveillance mechanisms that could get a lot more information about each and every one of us. And yet, when it's most important to our health and safety, that information is a lot less portable than we ourselves are. And so, our research collaborative, University of Toronto affiliated, is trying to take an aerial view with big data and trying to see how we can massage all of this together to reobtain signals of insight, but also dive deep at the intra-individual level. So the bench scientists doing the translational work and the microcosm that is each individual suffering a reaction has also been an area of our interest in this kind of multidisciplinary mode of research with Canadian Blood Services and the teaching hospitals. So with the acute transfusion reactions, you can call them earth, wind, and fire, if you will. And our transfusion reaction policies are really biased to get that blood bank specimen because we're always most concerned with whether or not we may have dispensed something incompatible. And of course, hemolytic incompatibility can present in numerous ways, including with off-target cardiorespiratory features. And of course, the manufacturer is concerned with whether or not there may be a bacterial contamination. And so high-risk fevers really drive the two key cultures of testing, hemolysis and incompatibility. And where we have some fuzziness is what should that standard of testing be, given that a lot of the stuff isn't happening in the blood bank proper. We're not a core lab per se, we're a diagnostic lab with respect to compatibility testing. But what ought to be the core facets of cardiorespiratory investigations. And this has sort of been kind of up for debate, especially in our own transfusion transmitted injury surveillance system with respect to trying to promulgate a good standard of investigation. So, hemolytic investigations tend to have low yields in many of the archetypes, and septic transfusion reaction investigations are often poorly executed with things not retrieved for adequate both face cultures of the patient and the product if we really wanted to get that adherently done. And as I mentioned, respiratory reactions are often unstandardized. So the differential diagnosis for fever, each of you is familiar with, and many hospitals will practice I guess a choosing wisely way of approaching fevers in that low risk deflections may get tests waived in the interest of, not capturing low pretest probability events for the things that we really care about. So if it's a high risk fever, yeah, we're looking for acute hemolytic reactions and bacterial contamination, but otherwise it may be an FNHTR unless it's a fever due to the underlying disease. And FNHTRs are diagnoses of exclusion. And again, the danger gradient runs counter to the frequency gradient. So we do pause and we give an option to medicate and continue as long as it stays low risk, which is a Tmax that stays underneath 39 and has no symptoms or signs. But if the patient notices what they're going through in some symptom or sign, or their temperature goes above 39, we cease and desist. So I'm not going to kind of blow up here the pathophysiology of acute hemolysis, because I think that's going to be spoken to in other sessions. But again, our bias is always to look for hemolytic reactions, and there are core ways to look for that. And we rely as well on biochemical markers and not just the blood bank specimen. And examine blood and urinary compartments. And in the blood bank, paying attention to the retyping, the DAT, and if having suspicions gleaned from the appearance of the plasma or any of these foregoing tests. Second tier testing will be to look at the eluate and maybe to even serologically recross match with the involved unit if it was a red cell. So we may be looking for DIC as evidence of hemolysis, complement consumption, and ferritin surges. And so the reality today is that there are many more antigen systems or allelic variants that may be immunoprovocative than there are antigens that are represented by the 2 or 3 screening cells on a group and screen. And so there's always that margin of fallibility. And so this is sort of where we take interest in sometimes diving a little deeper in some of these investigations if they look suspicious. And you can take a wider opsonic berth to this serology that we do in the blood bank. Some of our antibodies fix complement, or sometimes complement is getting deposited and activated in and of itself. And so there's immune-mediated and non-immune mechanisms of erythrodestruction. The patient may have an underlying immune hemolysis, cold or warm, but of interest to blood banks is whether or not there's an alloimmune polarity at stake. Is this a passive event, a graft versus host, preformed antibodies from a yellow stuff type product versus a patient immune system rejecting a transfused red cell. And that can be a seropositive event or a seronegative event, as we sometimes see in hyperhaemolysis. And as I mentioned, complement may be depositing in a non-immune way due to underlying patient conditions or infections. There may also be enzymopathies in the donor or in the recipient interacting with the drugs of either. And so that's also something to consider in seronegative outcomes. And from the component maker's perspective, there's always this paranoia that maybe something infected got dispensed. And this is a nice glom of pus seen in the era before pathogen reduction. This was actually a unit that was given out to a patient. And were it not for this coagulum arresting the flow of that unit, this patient probably would have been transfused with a potentially lethal quantity of this coagulative staph. So FNHTRs, they do occur commonly, and it was thought, at least in the days before leukoreduction, that this was the dominant mechanism. But now that we leukoreduce, there may still be pyrogens oozing out into the supernatant of the product from the cell matter within. And so Nancy Heddle is a great hero of mine, and she published really beautiful research in the 1990s trying to unpack the mechanism of FNHTRs, showing that post-storage filtration was not as effective as decanting off the problematic plasma that carried some of these pyrogenic mediators, and further demonstrated this in a beautiful New England Journal paper looking at platelets that were split by their decanted plasma and the cell matter, some leukoreduced, some not, to again reestablish the fact that these pyrogenic mediators were sitting in the soluble material and not from the isolated cells themselves. So in summary, the pyrogens or pyrogenic mediators may be the leukocyte content, especially true if we're dealing with non-leukoreduced materials, and cellular outputs over time, including platelets by themselves, even in leukoreduced products, essentially exude a waste into the plasma supernatant. And a day 7 platelet is kind of like a day 28 red cell as we speak to longer stored products. And immune complexes may also be playing a role if patients are confronting incompatible antigens. Now, flipping over to the respiratory side, my acronym here is going to be cardiorespiratory transfusion reactions, but I'm talking about the wider canon of various dyspneas that are transfusion associated. So these are regarded as the most important of all transfusion hazards, chiefly because there's such high case morbidity and mortality rates, operating with a high frequency, and representation, therefore, for the majority of tabulated transfusion-related deaths. And that's all over the world. And TACO has now eclipsed TRALI in this sense of about a third versus 1 in 5 of the fatalities being caused by cardiogenic versus non-cardiogenic distress. And so our differential diagnosis here, again, is cardiogenic or non-cardiogenic. And if it's not a non-cardiogenic pulmonary edema, there may be a bronchospasm or an anaphylaxis phenomenon at play, or a crossover off-target manifestation with capillary leak occurring downstream of a hemolysis or contamination event. If it's not the underlying disease, then TAD is essentially the FNHTR equivalent here. And volume status is the discriminant in these post-transfusion pulmonary edemas with a 2-hit model. And so red cells are a more congestive product, and the humorally rich materials of plasma and platelets, if they're not pharmaceuticalized or pathogen reduced, so to speak, are the ones that are going to be bestowing the highest risk when it comes to the leukoagglutinins of a dangerous donor. We sometimes joke that it's the dangerous doctor in a cardiac stress event that distinguishes the cardiogenic event. So again, the 2-hit model, anti-leukocyte antibodies dominating as a mediator. But if it's not that, then imputed are these biologic response modifiers, be they biologically active lipids or other cytokines, chemokines, nets, and mitochondrial DNA. And product factors, the amount of these evil humors cooperating with how primed the patient is, would together predict for or perhaps explain the severity of the outcome in that particular interaction. And TRALI has been mitigated by identifying the so-called femme fatale effect. The commonest way for those healthy enough to donate would be sensitization to leukocyte or red cell antigens via pregnancy. And it's those leukoagglutinins that are the problem. And so Everparis whole blood is, of course, managed differently from those who don't have that anatomic or biologic risk factor. There is, however, the duality of TRALI sometimes being indistinguishable from TACO, so not being able to rule out both converging in the same patient. And why not? We've got biophenotypic leukemias, we've got nucleic acids that are both information coding and enzymatic in their nature. So sometimes 2 things happen at once. Now, the residuals after gravidity mitigation, again, biologically active lipids. So, is there a testing or conclusion dismissal bias if we don't see anti-leukocyte antibodies? Conversely, are there more or less anti-leukocyte antibodies than we think because we don't test all of these cases? And is it potentially discoverable that anti-leukocyte antibodies are less pathospecific than we think? Chris Silliman was the original pioneer champion of this idea of biologically active lipids, and we have the fortune of working with Mark McVeigh over at the Hospital for Sick Kids down the street from us, who is very interested in ceramides and S1P. So some of these biologically active lipids and these more precise characterizations as endothelial disruptions and observing this effect with longer stored platelets, for example. It is interesting, a case report from Sunnybrook just 2 years ago with only 15 mils of a red cell unit from a 63-year-old female donor given to a 69-year-old grand multipara with cancer who died within 24 hours of only 15 mils of this red cell. And what was found were a host of donor side antibodies that were cognate with the donor profile, and yet how much soluble or cellular HNA or HLA material could there have been in just 15 mils of red cells? What was also interesting was just how multi-sensitized the donor was with class 2 HLA antibodies. But again, even narrower than how much of these class 2 antibodies could have been in that theoretical 1 mil or so of supernatant plasma, that 15 mil, literally dead space level infusion load. So this paper didn't characterize the recipient's white cell type to see if there was anything cognate there, but certainly cause for pause. And this blood paper came out a couple years later that suggested that maybe reverse trolley may be in the red cell supernatant itself. And so neutrophil-specific receptor presenting the proteinase 3 autoantigen on the neutrophil surface, released or enhanced by that filtration and longer storage process, where the host has the anti-CD177 antibodies interacting with that soluble junk. And here we see the endothelium disrupting as a result of that interaction. So maybe we'll learn more about how such a small amount of red cells can do this and what the exact nature is of reverse trolley. TAD is our epidemiologic dustbin. So if it's not TACO or trolley or an allergic bronchospasm or an underlying condition, we get to call it TAD. And TAD, as I said, is analogous to FNHTR. And so it's interesting that trolley and FNHTRs are mirror images of each other with respect to whose body or whose direction the anti-leukocyte antibody is coming from. And in turn, FNHTRs may sometimes be dyspneic and trolleys may sometimes be febrile. Now, on the allergic front, we all have our elementary understanding of mechanisms of anaphylactic or allergic type reactions, as well as the anaphylactoid canon of individuals who are hypomorphic for a protein who then sensitize to the wild type. And then by that anti-protein IgG, or whatever that is a surrogate of, reproducibly have escalating severity reactions that require washing, although that's not possible with plasma. So IgA deficiency informs our testing because it's something that we can do something about, given that we have these Rolodexes of donors who are suitably IgA deficient if we need them. Now, investigating anaphylaxis is something that's typically not done because these mucocutaneously manifested events don't need a biomarker to prove themselves. But if we wanted to look at the undercurrents or evidence, if someone just has a pure shock reaction, we've sometimes tried to order these biomarkers, though we have to be mindful of the fact that histamine is a very short half-life marker in contrast with tryptase. So if you have to make a choice here, I would probably go for the latter. And hypotension kind of draws back some of the aforementioned factors or disturbance types that have been mentioned. So acute hemolytic reactions, bacterial contamination, and an anaphylactic event, and bradykinin shock as a potential cause of hypotension. And here the mechanism here, bradykinins, which are vasodilatory peptides present in blood products, poorly broken down in those taking ACE inhibitors due to the interference with bradykinin clearance from the effect of that enzyme. Excess bradykinin as a result, producing the flushing, hypotension, dyspnea, hypoxia, conjunctival injection, sometimes these clues that could be misconstrued as an allergic response. And so we don't often chase these events with an exacting biomarker to prove exactly what happened in retrospect. Now, we've often wondered if TAD really is its own entity, or is this a dustbin element because it's a milder or mixed version of existing entities? Who knows? And so I have this bias of favoring a description of what happens by the presenting features rather than by the final diagnosis, because the final diagnosis is sometimes couched in weak probability language, and sometimes we've got more diagnoses than there are people or disturbance referrals, just because so many possibilities get acknowledged at the end of the day. And so the truth, unfortunately, is overlap. And we can see that from the archetypes, you've got minors and majors together. And there are some dualistics. So we have some febrile cardiorespiratories, the febrile shocks. We have explanations or differential diagnoses for, but there is such a thing as hot taco. And febrile taco does appear to be quite common. About a third of our tacos manifest in fever, even if we pull out those who didn't start with a fever. Some interesting ideas on how this might be happening, maybe a fluidic angioplasty effect. And when we compare the occurrence of fever and allergic reactions, which themselves are immune complex events, we find that taco has a much higher odds of fever in either direction, starting off with or finishing with. This interesting paper on a touch of trolley illustrated a hot taco phenotype, but when they went to actually look for anti-leukocyte antibodies, they found them. And so again, it raises the question of, if we only dig deep enough, would we find the real explanation for what we think we're giving another name to? For febrile allergics, could this just be two different reactions, or could this be a single mediator that is capable of doing both things, like CD40 ligand? And finally, with allergic cardiorespiratory, a very interesting paper got published last year on this sequence of events beginning with anaphylaxis and culminating in a taco, a histaminergic adrenergic sequence, crashing the blood pressure and adrenergically overshooting in the compensation. So Dr. Badami from New Zealand described the attack complex, which is an adrenaline Takotsubo anaphylaxis Kunis complex. So taco to make it memorable. Taco, T-A-K-O, referring to the Takotsubo or broken heart phenomenon of an extreme sympathetic stress related damage to the myocardium, and Kunis syndrome, speaking to the power of severe allergic reactions inducing acute coronary syndromes. And so there's an acronym within an acronym here, the attack complex, or TAC, transfusion associated attack complex. So said that this really should be considered in the sequence of severe allergic reactions, and maybe this is occurring more often than is known. And so effect considerations at the end of the day, quantitative and qualitative interactions with the amount of mediator and host heat up, so to speak, may converge in the final outcome. So it is difficult to work up reactions because patients are often sick. We've got information gaps, and there are these overlaps, as I've alluded to. And many times we are not certain that we could rule something in or rule something out. And so that leaves us with a lot of possibles. The sick patient accounts for a lot of our reactions, and dyspneic reactions follow as the most common after febriles and allergics. And so these are nothing to scoff at. And if we look at our dyspneics, they're very often no stronger than possible in our probabilistic assignment. And what's unfortunate about the respiratory reaction patient is that their underlying condition and its progress may be the explanation, while also being the risk factor of that priming state that leads to that particular transfusion sensitivity. And so a lot can converge on the alveolus in terms of interacting factors. And we decided in the tadpole study to see if we could reconstruct patients with an agnostic kind of 6-dimensional profile of each reaction, so as to give voice to the fact that there's complexity to each individual, or so-called multifactoricity. And so our U of T teaching hospitals contributed to this study, which was to do this agnostic battery of tests on individuals, and to see if that enhanced the confidence in the diagnoses and acknowledge the true multifactoricity of individual presentations, as well as looking at what the biomarker signatures were of the presenting archetypes and the individual final diagnoses. So we enrolled 151 patients and found, counter to the work of Rick Kapoor, that C-reactive protein was completely nonspecific in cardiorespiratory versus febrile reactions, and the bradykinins weren't helpful at all in shock reactions versus other blood pressure deflections. And NT-proBNP was only helpful to us as a TACO rule out. Now, on the delayed end of things, TAGVHD has a mitigation, and hyperhaemolysis has been likened to PTP in the sense of this grandiose bystander takedown, and yet these two things are very different in their frequencies. We see hyperhemolytic DHTRs quite often, and quite frankly at UHN, because we have such a big hemoglobinopathy population, it is the leading cause of transfusion-related death over the last 11 years at our hospital when we compare it to cardiorespiratory events. And so I won't belabor the fact that this is a reconfrontation and reactivation event where healthcare fragmentation or missed antibodies play a role. But some of our preliminary data on our hyperhemolysis experience with 40 patients is quite grim. So we have an almost 20% case fatality rate. One person was successfully bone marrow transplanted. Many of our patients, almost 30%, have a seronegative signature, and we get a lot of these historically dismissed glycophorin type antibodies being a co-signature in these seroconversion events when patients present with hyperhemolysis. The MMA hasn't helped us and sometimes led us into false reassurance with a transfusion that culminated in a fatality on a re-exposure. And though we haven't had a lot of access to eculizumab, rather, 1 in 4 of our cases thus treated nevertheless passed away. So it is interesting that the pro-eruptotic humors can occur even in seronegative cases, which raises the question of whether or not we're not seeing an antibody that's there, or it's not an antibody at all or alone. And we have some anxiety over maybe our own reagents being quote unquote racist. So do our screening cells adequately represent the low prevalence antigens that may be provocative to our patients who are getting ancestrally profile similar blood? And for those that don't do anti-human globulin cross matches at dispensation, or whose anti-human globulins don't have sensitivity to the isoallotypes of the IgGs of our patients, that maybe we have blind spots in our reagents, which is disconcerting. So free heme may be an evil humor in and of itself, setting off your PAMP and DAMP pathways with our endothelial toxicity and innate pattern recognition motifs, converting macrophages to pro-inflammatory versus anti-inflammatory behavior types, broadening what might at first be a specific antibody into non-specificity behavior, and even inducing complement cascades. So now at the end of the day, we're appreciating that plasmas and supernatants, no matter what they contain, are not innocuous, be they acute or delayed, and we're still figuring things out. And so to conclude on the pathophysiology of reactions, I think we need to be aware of bias. So how much of what we see and report reflects artificial separations or a singular emphasis or blindness or neglect. In terms of bedsiders, so the clinicians, the laboratorians in everyday care, better matching, better information sharing, and better mitigation strategies. And finally, the benchers. Maybe, this translational work will come to a rescue with respect to the underlying identities to diagnoses of exclusion, TADS, and these mixed picture presentations, and ultimately, because it's such an important diagnosis, the causes and potentiators of hyperhaemolysis. So thank you for listening.
Well, thank you very much. That was fantastic. And I really congratulate you on putting things together in a way that we can remember them. So the bias benchers, bedsiders, and I loved your informed consent concept, because I think that really makes it much more clear to patients. I'd also, there aren't any questions, but I'd also like to thank you so much for including so many references in your presentation, because from an educational point of view, this is fantastic. And we do expect to share this with all of our members and all participants. And this will be a fantastic resource as we explore more the pathophysiology of transfusion reactions. So thank you very much. And I still don't see any questions, so we'll move on to our next speaker.
Thanks very much, Babi. So now we have Dr. Anicee Danaee. Welcome, Anicee. She's a consultant hematologist at Guy's and St. Thomas NHS Foundation Trust. She's also a member of the SHOT Working Expert Group, and she works with other panelists who have been here today on the hemolytic transfusion reaction cases as well. So today she would be actually presenting to us more about the pathophysiology of hyperhaemolysis. Over to you, Anicee, and we can see your slides. I think it just needs to be in the slideshow mode. Fantastic.
Thank you very much, Shruti. Yes, my name is Anicee. I'm a hematology consultant at Guy's at St. Thomas's Hospital, and I've been tasked with covering hyperhaemolysis, or the pathophysiology, of this afternoon, so I shall try my best to give you an overview. Hyperhaemolysis, or hyperhaemolysis syndrome, as most of you know, is the most severe form of a post-transfusion hemolytic reaction. And although these are rare, they have potentially devastating consequences. Hyperhaemolysis syndrome has been reported both in children and adults, and most cases are described in patients with sickle cell disease, although there are some reported cases in patients with other hemoglobinopathies, as well as patients with other hematological conditions. The actual incidence.
Anicee?
Oh, sorry. Yeah.
Sorry to interrupt. If you can move your mic a little lower, please. I think it is too close. Yeah, a little bit of an echo. Yeah, great. Thank you.
The actual incidence is unknown, and the diagnosis is often challenging and requires a high index of suspicion. And the risk factors for recurrent hyperhaemolysis and possible differences for primary and recurrent episodes remain largely unknown. So the common features of hyperhaemolysis are that patients generally develop a drop in their hemoglobin to below pre-transfusion levels, with destruction of both autologous and transfused red cells. This is accompanied by reticulocytopenia and hyperferritinemia, and in many, although not all patients, an absence of a new detectable alloantibody. That graph there, which is from a review in the British Journal of Hematology earlier on this year, looking at epidemiological and clinical features of hyperhaemolysis, shows the common presenting symptoms, which are pain, fever, and dark urine. And you can see why, therefore, a high index of suspicion is required, as those are also presenting features of a vaso-occlusive crisis in patients with sickle cell disease. Now, what about hyperhaemolysis versus delayed hemolytic transfusion reactions? I mean, we all know that not all physicians believe that hyperhaemolysis is a clinical entity that exists. Some patients feel that this is just a more severe form of a delayed hemolytic transfusion reaction. But whether we choose to label it as hyperhaemolysis or not, those of us who see patients clinically know that it exists clinically, and those patients are often very difficult to treat. In short, we use the same definition as was used by Nay Win many many years ago now, whereby hyperhemolysis is divided into acute and delayed, with the acute hyperhemolysis generally occurring in the first 7 days following the transfusions. And those are the patients whereby there is that destruction of both transfused and autologous red cells with a profound reticulocytopenia. Often these patients generally have a negative DAT and no new antibody is identified. If we looked at the other end of the spectrum with the late hemolytic transfusion reactions, these are a little bit different in that generally there is transfusions and destruction of transfused red cells with a reticulocytosis, in keeping with what we know happens in hemolysis, generally a positive DAT, and these patients often do have a new alloantibody. And then in between are those patients whereby there is a drop in hemoglobin to below pre-transfusion levels, but who also develop an antibody. And so I suppose these are all on a spectrum of disease, and how we choose to label them is not as important as the fact that actually they vary in severity, and the treatment of those patients with severe hyperhemolysis and profound reduction in their hemoglobin is a little different to your average delayed hemolytic transfusion reaction, which is often self-limiting. So what about the pathophysiology of hyperhemolysis? I suppose in summary, no one really knows what the pathogenesis of hyperhemolysis is, and there isn't a scientifically proven mechanism as yet. However, there are several theories with regards to hyperhemolysis, which I'll try my best to go through. So the key features, as we've discussed, are destruction of autologous and donor red cells. It also doesn't occur in all patients with sickle cell disease. If we look at the reported case series and case report, it tends to occur more frequently in women than it does in men. It has been reported both in patients following a transfusion in the context of being acutely unwell, as well as patients who have elective exchanges, for example, preoperatively. And there is a tendency for recurrence in the same patient following subsequent transfusions, whether this is a few months or years later. There are reported cases whereby hyperhemolysis occurs in the same patient again. And this suggests that there must be an immunological or genetic predisposition in some patients more than others. So what are some of the theories behind the pathophysiology of hyperhemolysis? These are some of the common theories in the literature. There is the idea that there is an element of macrophage activation, bystander hemolysis, as well as complement-mediated destruction of red cells. So what about macrophage activation? Well, this is a really nice report by Nay Win from a few years ago now, looking at histopathological evidence of macrophage activation. And in the absence of detectable antibodies in acute hyperhemolysis syndrome, it is thought that macrophage activation and erythrophagocytosis are an alternative mechanism. And in patients with sickle cell disease, certainly we know that there's already a pro-inflammatory state, and the sickle red cells generally tend to adhere to macrophages more easily than non-sickle red cells, and therefore a more rapid clearance of red cells leading to the reticulocytopenia. And at the same time, during phagocytosis, ferritin is released, resulting in a hyperferritinemia, and we know that these patients often have a reticulocytopenia and an elevated ferritin. And in that particular report, bone marrow examination, as well as autopsy in one of their cases reported in that report of the liver and spleen, showed quite significant infiltration by macrophages and erythrophagocytosis. And how about our treatment strategies then, which might support that there is an element of macrophage activation? So first-line treatment in these patients is generally steroids and IV immunoglobulins, whereby steroids are thought to inhibit erythrophagocytosis and the IVIG suppress macrophage activation. And then more recently, there have been some case reports of the successful use of tocilizumab in some refractory cases. Tocilizumab, which is used in other inflammatory conditions such as rheumatoid arthritis, for example, is a monoclonal antibody against interleukin-6, which binds to the interleukin-6 receptor and reduces the pro-inflammatory effect. And that suggests that clearly there is a role for tocilizumab in at least some patients by reducing that macrophage activation. And the other theory, which is was first proposed in the 90s really is that of bystander hemolysis of autologous red cells, whereby the process is activated by antibodies against donor antigen present in the patient's serum. And you have this immunological accident where you have red cell destruction, which not only destroys your mature red cells, but also your erythroid precursors. And complement activation has been suggested as a potentiator of bystander hemolysis. And we then move on into complement. So for those of you who are interested in immunology and understand immunology and would like to know more about it, this is a very good review looking at the role of complement in post-transfusion hemolysis and hyperhemolysis. And I have simplified this mainly for myself with my non-immunology hat on. And the way that I understood the role of complement is that essentially the innate immune complement system is clearly important in post-transfusion hemolysis, contributing to red cell destruction. And that complement is involved during different stages of hyperhemolysis. So initially as a trigger for the reaction through the classical pathway, but probably also through the alternative pathway. It contributes to the amplification of the inflammatory response through release of pro-inflammatory components and is an enhancer of tissue damage. And in sickle cell anemia, chronic anemia, and release of free hemoglobin can also affect complement activation. Serological studies don't always provide an explanation for hemolytic transfusion reaction. As we have already discussed, not all patients develop a detectable antibody, and a significant proportion of those patients who don't necessarily develop antibodies which are thought to be clinically significant, and the severity of the reaction doesn't correlate with the type of antibody. So one theory is that heme, which is released during the hemolytic process, can modulate the reactivity of immunoglobulin, leading to red cell lysis without prior immunization. And so how about using complement as a therapeutic strategy or complement blockade? Well, we know that there are features of intravascular hemolysis, and in patients with, for example, paroxysmal nocturnal hemoglobinuria or hemolytic uremic syndrome, we know that anti-complement agents are used successfully, and the efficiency of eculizumab as an anti-C5 blocking antibody on the process, we know that works in those patient cohorts. And by blocking the effects of both the IgG-mediated classical pathway and alternative pathway using anti-complement therapy, we might be able to control red cell destruction. And so certainly in the UK, eculizumab is generally used as a second line in those patients who don't respond to IV Ang and steroids. But of course, these are all case reports and case series, and really we don't have very many large numbers of patients treated with eculizumab, but complement inhibition certainly promises to be an efficient therapeutic strategy. And so really, I suppose, in summary, as you can see, there are various plausible mechanisms leading to hyperhemolysis, but actually we need further studies to delineate the underlying pathophysiology to allow us to prevent, but also optimize and maybe personalize treatment strategy for patients. It is also possible that there might be multiple subtypes of disease with variable contribution from different pathophysiological pathways, and our treatment strategies currently are variable. There are a number of agents that exist in those patients who are refractory, but the evidence is only from case studies, and larger studies would be welcome. And in addition, what would be really good is identifying biomarkers which can select those patients who will most benefit from particular treatment strategies as necessary. So I hope that this gives you an overview of the pathophysiology of hyperhemolysis. And with that, I will finish my talk.
Fantastic. So thanks very much, Anicee. I think, yeah, if you can stop sharing your screen as well, but this was really a great overview, and thanks for, again, providing all the references as well. So are you okay to stay till the end of the webinar, Anicee?
Sure.
Because I think there are no active questions that have come in, but I think it would be useful to pose the questions to the whole panel as well. But fantastic. Thank you, Anicee.
Thank you.
It is my pleasure next to actually introduce Tracey Tomlinson. So Tracey is a biomedical scientist by background and is the national lead for patient blood management at NHSBT. She is also part of the short working expert group in the steering group, and she has been reviewing the hemolytic transfusion reaction cases and contributes to the annual report as well. And in her previous role, she was the head of the red cell immunohematology laboratory at Collindale. And it is great to have her here today to present on the laboratory aspects of hyperhemolysis and hemolytic transfusion reactions. Over to you, Tracey, and we can see your slides very well. Thank you.
Oh, thank you. That was going to be my first question. Thank you, Shruti. So thank you for inviting me to speak today. So I'm really going to go through the steps that we perform in the laboratory to investigate hemolytic transfusion reactions with an emphasis on hyperhemolysis. So every country will have their own guidelines to follow. Within the UK, we follow the guidelines from the BSH, the British Society of Haematology, and the guideline on investigation and management of transfusion reactions has just recently been updated. So we have a 2023 version available. So whenever we get a transfusion reaction, that is our first point of call to how we investigate it. So for any hemolytic transfusion reaction, as Christine mentioned in her presentation, there's an emphasis on sample collection. Really, we want to try and get those samples collected as soon as possible, because once we start any interventions to treat the patient's symptoms or try and manage the reaction, we lose some of the ability to test those samples. So we try and want to get those through as soon as we can to get them to the lab. So the investigation of a hemolytic transfusion reaction is a number of steps that we perform to look for evidence to try and give us clues of what's happening. So the first thing that we would do is repeat compatibility testing, and often that will be doing the testing on both the pre and the post transfusion sample. If you've used electronic issue, for example, you'd want to do an IT cross match on both. And we're looking for differences. So are there any differences in the result post transfusion that you might have missed pre transfusion, which indicate that there's some sort of serological or immunological reaction occurring? Have there been any new antibodies detected post-transfusion that weren't detected pre-transfusion? Is the DAT positive, or has it changed? Because often patients' DATs might be positive pre as well as post for a number of reasons. But what we want to see is, has it become positive, or has it changed? Has it got stronger? And also, have there been any antibodies identified in the eluate? So sometimes you might not find them in the patient's plasma, but you might find them in the red cells because they've in the eluate because they've all bound to the red cells. And each of these can give you clues. So as Anicee said, in a patient who has experienced an acute episode of hyperhemolysis, the DAT may be negative, as in contrast to a patient who's had a hemolytic transfusion reaction, a classical delayed or acute, or a patient with a delayed hyperhemolysis episode. The next test that we really look at is the blood count. That gives us lots of clues. So we want to look at, has the HP dropped post-transfusion? And has it just dropped back to pre-transfusion levels, or has it dropped below pre-transfusion levels? If it's dropped below pre-transfusion levels, that gives an indication that the patient is hemolyzing the transfused cells as well as their own cells. Also, has there been any change in reticulocyte counts? So within hyperhemolysis, classically, you will see a drop in reticulocyte, and that can really help us to distinguish between hyperhemolysis episodes and other types of hemolytic transfusion reactions. We then go into the chemistry lab, and we look to see if there's been any change in the patient's bilirubin or LDH. It's not a classical test for transfusion reaction, but it might also be useful to test the patient's ferritin level. And sometimes that can be seen as a marker for macrophage activity, which can sometimes be seen in hyperhemolysis as well. Other investigations you can do is you want to do some urine analysis. So is there evidence of hemoglobinuria? This is common in transfusion reactions, but also you can do the HPLA test in the urine to look to see how much of HbA or HbS is still available. Similarly, you might want to measure the patient's HbS level if they're a sickle patient, to see as an indication to see if they are transfusion both their own cells and the donor cells. And this can be a very easy way of doing it in those patients who have got an abnormal hemoglobin. If that's not possible, you can do a similar thing by looking at phenotypes. So you might see a mixed field because there's presence of the patient's own cells as well as the donor cells, which will then disappear as the donor cells are being consumed. In hyperhaemolysis, where both types of cells are being consumed, you might not see that moving so quickly. And in the immunology lab, you might want to do a haptoglobin level to see if there's been any change in there. However, what you need to remember in all of these tests is that also depends on the patient's underlying clinical condition. So you might see some of these changes in these results as an outcome of the patient's underlying condition rather than as a reaction. So for example, the HB might drop because the patient's bleeding. The bilirubin might be increased because the patient's got liver disease or gallbladder issues or Gilbert's disease or is on some drops. LDH could be increased because the patient has some cancers, some infections or inflammatory responses. So you really have to be careful when looking at these results, and you need to look at them as a jigsaw. So you can't look at them in isolation. And once you've got those results, you can put them all together to see actually what do they suggest? What are they suggesting? A hemolytic transfusion reaction? Are they suggesting hyperhaemolysis? Are they suggesting it's just the patient's underlying condition or something else? So really in hyperhaemolysis, we're looking for the hemolysis continuing even after the transfused cells has been removed from the circulation. The hemoglobin drops way below the pre-transfusion levels, indicating that both transfused and patient's own cells are being consumed. As Anicee said, the DAT is often negative and no antibodies in acute tests, and the absolute residulocyte levels drop. And then finally, the most important thing is to submit your report for a hemovigilance scheme. So all the information that we have on transfusion reactions and how to investigate them and how to treat them and understand them comes from the case reports that get reported and the data that we can collect. And the more information we have on any type of reaction, the better the information that we can base our conclusions on. So that very quickly is a guide to transfusion reactions and how we investigate them in the laboratory. Thank you.
Thanks very much, Tracey. A lot of practical pointers there as well. So yeah, we'll take the questions towards the end. And moving on now to Dr. Joe Sharif. So he's a consultant hematologist at Manchester University NHS Foundation Trust and is the adult lead for sickle cell disease. He's also the deputy lead for the Northwest Hemoglobinopathy Coordinating Center Network. He's a core member of the National Hemoglobinopathy Panel and is also a member of the SHORT Working Expert Group. He writes the summary chapter on the reports relating to patients with hemoglobin disorder, and he's now going to provide the clinical aspects of hyperhemolysis. So please do, I think, for all our audience as well, please do put in your questions, and we will have some time towards the end to cover all of these. Over to you, Joe, and we can see your slides.
Thank you very much, Ruthie. Yeah, so I'm going to talk about some of the clinical aspects, particularly focused on cases that we've seen. So I'm going to review the cases reported in the literature. I'll then look at the cases that have been reported to SHOT over the last 15 years, and then discuss one particular severe case that I was looking after in more detail. So this is a systematic review which was published just this year, which has reviewed all of the cases of hyperhemolysis in the literature, and they've summarized them quite nicely. So there's been 51 cases that they've included in the analysis of hyperhemolysis, and 61% of these occurred in patients with sickle cell disease. The second most common conditions was in the beta and alpha thalassemias, and then there's the odd cases just in some other conditions such as hematological malignancies and some other conditions as well. And 65% were in females as well. Looking at the clinical features, the most common clinical features were pain, fever, and hemoglobinuria, occurring in more than 50% of cases. And then looking at the key laboratory features, so the median hemoglobin nadir was 3.9 with a range as low as 1.8 up to 7.6. New antibodies were detected in 39% of cases, and the DAT was positive in 21.7% of these cases. Looking at treatment, so over 70% received both received corticosteroids and immunoglobulin, usually in combination. 42% received EPO, and then we see there's been a smaller number of cases, around 15%, with using both eculizumab and tocilizumab. And as you can see, additional transfusion is also being given in 60% of cases. And some of the key outcomes were overall time to recovery or hospital discharge was a median of 18.5 days. There was 3.9% deaths, so there was only 2 deaths out of this these cases that have been reported. And interestingly, patients receiving further transfusion experienced a longer hospital stay or time to recovery of 23 days compared to 15 days in those who didn't receive an extra transfusion. So moving on to SHOT. So this shows a summary of the hyperhaemolysis cases reported to SHOT over the last 5 years. As you can see, most of the cases were in patients with sickle cell, but again, to point out that this condition can occur in other conditions, so it's important for all clinicians to be aware of this potential diagnosis. So looking at all of the SHOT data, we've looked in more detail at the hemolytic transfusion reactions, particularly in sickle cell, over the last 15 years. So this has not yet been published, but it is available if you look in each of the individual SHOT chapters. So over the last 15 years, there's been 671 total hemolytic transfusion reactions reported, and out of these, 144 are in patients with sickle cell disease. So this is the ones I'm going to focus on. Of those, 74 were hyperhaemolysis cases, and there's a total of 8 deaths. So 6 of these were in patients with hyperhaemolysis, and transfusion was considered attributable in 4 of those cases as well. Looking at the age and gender distribution of the sickle cell hemolytic transfusion reactions overall, median age was 28, but with a range from age 5 all the way up to age 74. And again, consistent with other data and all the literature, much more common in females, with 72% of all of the reports occurring in females. Looking at the context of transfusion, as it's been highlighted in the literature, that the transfusion given in the acute setting seems to be when transfusion reactions are more likely to occur. So 88% of the transfusions given in these cases were following an ad hoc transfusion compared to for patients who are on routine regular transfusion, and 13% were in the context of a pregnancy. And the indications are displayed in this graph. So anemia, pre-surgery, and VOC were some of the most common indications. For 30 cases, the indication wasn't clear. So looking specifically at the hyperhaemolysis cases, so there's been 74 cases of hyperhaemolysis in sickle cell over the last 15 years reported to SHOT. And looking at the transfusion history of these cases, so previous alloimmunization was in 47% of cases, and previous hemolytic transfusion reactions was reported in 10% of cases. And looking at the serological results following the reaction, there was a positive DAT in 70% of cases, and a new alloantibody in 33% of cases. And we looked at the hyperhemolysis cases and compared those to the non-hyperhemolysis, the ones that were classified as delayed hemolytic transfusion reactions. So as you can see, the median hemoglobin nadir was lower in the hyperhemolysis cases. There was also a trend towards a lower median time from transfusion to reaction. And I've just put in as well the cases occurring within 24 hours. So obviously the definition of a DHTR is occurring after 24 hours, so we wouldn't expect any of those to be within 24 hours. However, it's just to highlight that some hyperhemolysis cases do occur within the first 24 hours as well. Looking at the new alloantibody formation, this was much more common in the DHTR group, again, as you would expect, with only 33% antibodies in the hyperhemolysis group. And the DAT was positive, slightly higher incidence in the DHTR group as well. Okay, so I'm going to talk about this case of recurrent hyperhemolysis. So this is a patient who moved to the UK in 2017 from North Africa. So she didn't have, she wasn't under regular care in the country she was from, and she didn't have any medical history with her. She said she had required intermittent transfusions during her life, and she had a very mild right-sided deficit, which we later confirmed with imaging was from a previous stroke. So she first presented in 2017 before I was actually working in this institution. So her first presentation in the UK was a hospital admission with abdominal pain. And the initial bloods identified previous antibodies of big C and big E. And a decision was made to transfuse her during this admission due to a hemoglobin drop. She then presented 6 days later with all over body pain, and she was treated as a vaso-occlusive crisis. And it wasn't identified at this point that this was actually hemolytic transfusion reaction. Hemoglobin had dropped and a decision was made to give further blood. And as you can see from the graph, when she's given the further blood, the hemoglobin drops even further. And at that point, it was realized that this was a hemolytic transfusion reaction, and she was treated with immunoglobulin and steroid. And then she did make a recovery. And the repeat antibody screen did identify further antibodies at this point. So then 2 years later, she presented with a pregnancy. And unfortunately, the pregnancy was progressing well at the initial stages, but then she unfortunately had a stillbirth at 32 weeks. And then following the delivery, she then developed an acute chest syndrome and became very unwell and required a red cell exchange. And given her history, she was given immunoglobulin and steroid as prophylaxis. And she recovered from the chest syndrome. But then when she returned 1 week later, she then presented with hemoglobinuria and a hemoglobin of 45. So a further episode of hyperhaemolysis, and she was treated with further IVIG and steroid again. And no new antibody was detected following this episode. Fortunately, she did go on to have a successful pregnancy in 2020 and didn't require any blood transfusion during this pregnancy. However, in 2021, she presented to one of the local hospitals with right-sided weakness and sensory loss, and she was admitted directly to the hyperacute stroke unit for stroke treatment. So the MR brain confirmed a 2 centimeter left thalamic infarct with some hemorrhagic transformation. So there was initial talk between the stroke and the hematology team on how to manage. So usually for sickle cell stroke, the part of the management will be an urgent red cell exchange transfusion to prevent progression and prevent recurrence. However, given her past history, it was initially decided to manage conservatively, and we transferred over to the tertiary centre. She did, however, then develop a progression of her symptoms, and we had some discussions nationally at this point whether to transfuse or not. And we decided to give rituximab in anticipation that we are likely going to need to transfuse her because she'd previously failed IVIG prophylaxis. And we were also concerned about giving immunoglobulin and increasing hyperviscosity further in the context of the stroke. So she had a repeat CT scan which showed no progression, but we discussed with the stroke team and they thought there was likely an element of stroke in evolution. To further complicate things, she then also developed vaso-occlusive crisis and an oxygen requirement as well, so was heading towards a potential chest syndrome as well. And the weakness progressed, so the power in her arm was 3 out of 5, and also in the leg, and she was unable to walk. So we're in a really difficult situation here, so we were trying to decide whether transfusion would be of any benefit to try and improve her neurological symptoms, or on the other hand, would it make her more unwell by causing a further episode of hyperhaemolysis? So considering we'd given her rituximab, we also gave her methylprednisolone, and we did decide to proceed with an exchange transfusion, hoping that she wouldn't react. And this was following a national discussion and a national hemoglobinopathy panel, which we have in England. It was also discussed with the transfusion specialists, and we ensured we gave the best match blood. So it was negative for all of her antibodies, but we also matched for Duffy just to try and prevent any further antibody development as well. So during the red cell exchange, after 2 units of blood, we were doing it very cautiously with very close observations as we were concerned about a reaction. After 2 units of blood, she became really unwell, so severe all over body pain, hemoglobinuria, and she became tachycardic. So the blood was immediately stopped, and we thought at this point, she's probably having a hemolytic transfusion reaction. And so we decided to give her eculizumab. And she did seem to stabilize at this point, and then the hemoglobin following the eculizumab was 81, and we noticed the bilirubin had increased. And the following day, the hemoglobin had dropped down slightly to 73. However, clinically, she was much better, so she was off oxygen, and her neurological symptoms improved over a 24 hours, and then over the following days it resolved and she was back to walking around. The limb weakness had resolved. However, we wanted to keep her in for observation because of her previous history. We were very concerned that she may have a further episode of DHTR or hyperhaemolysis, so we were keeping her in, and even though she was very keen to go home at this point, we said she had to stay in for some monitoring. And as we expected, by day 9 she did have an acute drop in her hemoglobin to 47, and the hemoglobin A at this point was 23%, showing that there was some preservation of the donor cells, which is what you commonly see with hyperhaemolysis. So we gave her IVIG and methylprednisolone and transferred her to critical care for close monitoring. Now, the following day, the hemoglobin had dropped further to 29, and so we gave her a second dose of eculizumab for treatment of ongoing hemolysis, and she had become less responsive because the hemoglobin level was so low. We thought it was mainly due to cerebral hyperperfusion. So now we'd given her IVIG and eculizumab, we thought we might be able to give her a unit of blood because the hemoglobin was so low. We found it, we discussed this with lots of national experts, and we thought it would be best to give her a further unit. However, unfortunately, she reacted again and had a severe reaction during the end of the transfusion with severe pain and hemoglobinuria, which you could just see straight away in the catheter bag. So we had tocilizumab as our next line of treatment on standby on the ITU already, and we said if there's a reaction to give that straight away. So the blood was stopped and that was given straight away. And the ITU team said they could visibly see the improvement. So as soon as she'd had that dose, the fever settled, the pain all settled down, and we did a ferritin level pre and post, which showed the ferritin level was improving as well. So the following day, the hemoglobin was still low, so it was 24 at this point, and she'd become more and more unresponsive. And the critical care team were really worried at this point. Her EEG showed a general encephalopathy, and we thought it was all in keeping with just general cerebral hyperperfusion, secondary to having such a low hemoglobin. She'd also had a chest X-ray at this point, which showed lower lobe consolidation. And so now she had had tocilizumab, and because the hemoglobin was so low, it was really difficult. Once again, none of these decisions were very easy, but we thought that maybe now that she's had the tocilizumab and all the other treatments, maybe we could give her a unit of blood. So again, this was a very hard discussion with her family and things, but we thought we were going to lose her if we didn't give her blood at this point. So she had a further unit of blood, and again had a similar reaction. So she was quite unresponsive before the blood, and then once she had the blood, she sort of awoke and became very agitated and was in a lot of pain again, and we saw hemoglobinuria. So she had a further dose of tocilizumab, and again it all settled down. Following day, the hemoglobin had not dropped, so we thought that was a good sign. The hemoglobin was slightly higher at 29, urine was clear, and the ferritin had improved. At this point, we decided definitely not for any more blood under any circumstances, and just to continue with tocilizumab. And she was on all of the support in terms of hematinics and EPO and things to try and improve her hemoglobin as well. So fortunately, she did slowly recover over the course of that week, and hemoglobin actually came up to above her baseline with all the EPO support and hematinic support. There was a marked improvement in the neurological symptoms, and she was actually able to go home the following week. And the RCI investigations didn't identify any new antibody. And this graph just shows the progression of her hemoglobin and ferritin during the admission. And you can see when we gave each treatment, and the red arrows indicate when she had the blood transfusions. And as you can see, when we gave the tocilizumab, you can see a clear improvement in the ferritin level. And that's when we really saw the hemoglobin start to come up as well. So the patient's now doing very well. We obviously can't give her long-term transfusion for stroke prevention, so she's there put on hydroxycarbamide at maximum tolerated dose instead. So hyperhaemolysis is a significant, potentially life-threatening complication, as this case certainly showed, and particularly in sickle cell disease. Potential risk factors that have been highlighted are female patients, ad hoc and urgent transfusions, and a previous history of alloimmunization or a previous history of hemolytic transfusion reactions. So it's important to identify potentially high-risk patients, and it's important to carefully consider any transfusion decision, particularly in sickle cell disease, because of this risk. And consensus guidelines for hyperhaemolysis are needed to help clinicians identify cases and ensure that cases are reported correctly. And further research is required to help improve our understanding and help guide treatment for hyperhaemolysis. Thank you very much.
Thanks very much, Joe. And I think a complicated case and would have been actually a therapeutic nightmare as well to manage, but well done anyway. And thanks for sharing that experiences as well. And I believe that you're working up on the publication as well for that. So I think if I can ask all the other panelists as well to actually join us now. We have had a few questions, and I think Christine and Anicee have been actually then answering them away, but I think it is actually worthwhile bringing it back to because we have just under 10 minutes now for the discussion. And I think one of the key things that have been coming on is A, staff education, and then B is actually the patient shared decision making and consent. So I think it would be worthwhile, considering we are talking about all the risks related to transfusion, and I think tying in with what Christine mentioned, some may be, less frequent, but potentially fatal. And then you have the other end, which may be more milder. So I think maybe, Christine, if you want to kick off, and then others would also be actually then chipping in about both patient consent and staff education.
Yeah, it's a very good question. The literature on the quality of consent is not very flattering to us. There's a lot of room for improvement, and though I provided sort of a three-way matrix for framing the discussion, it still needs to be personalized. So when it comes to discussing the possibility of TA-GVHD, your patient may not be at risk, but if they are, it's an opportunity to reestablish and remind both parties, patient and clinician, that this person has a modified requirement. If it's a patient with sickle cell disease, we're going to emphasize hyperhaemolysis, like a taco style, second tier rising up to first tier risk, so that we don't underestimate or delude anyone on that realistic possibility of such a catastrophic outcome. We were very shaken by the death of a gentleman in his 40s. And it was his father's wish that we mention this on consent, because he and the wife of the patient distinctly recalled the consent not mentioning this at all. They remembered this clearly in retrospect. We had a gentleman who had definite bacon 2 times. Now, he was a BMT patient. The statistical odds of that happening, we computed to be like, 1 in 10 to the power of 10, and it happened in 1 in 37 sittings, or 2 in 37 sittings. So it was like winning a lottery like 3 times. It was just so improbable. He also didn't recall anyone mentioning bacterial contamination as a risk. So when these bad things happen and we debrief with the patient, we get feedback too on how poorly we did with getting consent from the patient. If this is a person with childbearing potential, the sensitization risk to red cell antigens is emphasized because it has an HDFN implication. Many, ladies choose not to get transfused when they hear about the implication of, 5 to 8% red cell seroconversion risk that could be cognate with their future baby's red cell type. When it comes to people on our transplant list, solid organ transplant individuals. So if you have renal anemia, which should be correctable with adequate erythropoiesis stimulating agents and IV iron, when they hear that HLA sensitization is at stake and greater difficulty with graft matching and or allograft rejection, many people opt out. And so when you have a really high quality conversation, it becomes a self-reinforcing, choosing wisely pact. We naturally head toward the more conservative transfusion avoiding outcome when that consent discussion happens properly. So it does take a lot of time. It's not something that you can do in 2 minutes. I've never been able to have a proper consent discussion in 2 minutes. I would feel like that's a theft from the patient. And so that, I think everyone kind of sits in their conscience with how that conversation is supposed to go. And I know we all have time pressures, but that's an upfront investment and it pays off in the long run. So do it right the first time. And sometimes questions come up afterwards, but that, that's part two, and that's interesting too. I mean, I learn from the patients all the time about what worries them, and I think that's very interesting for us to hear.
Thanks very much, Christine. So important. And I think from even our national audits that we have done, consent is something we can definitely improve on. And it is actually, I think, Tracey, you would be able to actually then say from the recent audit as well, I think it was well done or documented as well in only, I think, 30-40%, if I remember correctly.
Yeah, 30%. Yeah, closer to 30 than 40%. Yeah. Can I just add on to what Christine was saying? I think as part of that consent conversation as well, you have to make sure that you give the patient confidence to be able to speak up if they do feel any symptoms following the transfusion. Often, well, always a transfusion is given because the patient's unwell to an extent. And so often they feel like they've had their transfusion, they should feel better. And a lot of the symptoms of transfusion reaction are very similar to the symptoms of the disease. For example, in a sickle cell patient, hemoglobinuria might be the result of a sickle crisis rather than a transfusion reaction. So you need to give them that power to say, actually, I'm feeling unwell again. Could it be because of the transfusion rather than my underlying condition? And have that two-way conversation as well to give them that confidence to be able to speak up.
Yeah, a very good point, Tracey. Thank you. Joe, Anicee, anything that you want to add to that?
No, I agree with Tracey's point, particularly because if patients present acutely, often out of hours, seen by a general physician who might not know as much about hemoglobinopathy or the complications of a transfusion, if the patient is empowered and educated and asks that question, actually it will make them think about that possibility, probably more so than if the patient didn't bring it up.
Yeah, no, thanks very much, Anicee. The other question I had was one of the common things that we see reported under the febrile reactions, the febrile allergic and hypertensive reactions, is the untailored, like throw in everything, whether it is paracetamol, steroids, antihistamine. And is that a problem that you see as well, Christine, about how do you then tailor the treatment? And we are trying with our VEG members have actually then provided that algorithm to try and then channel, but it is always difficult when you have a patient who is actually reacting in front of you and then you want the best outcome and you throw everything in hoping that one of them will work.
Yeah, that's such an interesting question because it's married to the over pre-medication phenomenon that we witness, particularly, the primary pre-medication approach to someone who's not yet even demonstrated a propensity to react. So we see a lot of, primary over pre-medicated patients, and sometimes with the really sedative hypnotic stuff, the diphenhydramine. So that's a disservice to the patient. And yeah, it makes it difficult. I think the reason why some of our respiratory reactions are sometimes so hard to interpret is not just gaps in documentation or the complexity of the patient, but also, if something worked, how do you know which drug did? And at the same time, it could also feel like cruel and unusual punishment to do one thing at a time. If I have a very severe case of ITP, I'm not doing one drug at a time. I'm layering on medications if they have an unmeasurably low platelet count and they have a serious bleed. So sometimes we just accept that we'll never figure out what was working, but we had to go multimodal because this was a very severe presentation. But we do, so, when we database all of our reactions, and one of the things we pay attention to in every reaction is whether or not there was a breach in quality or something that could have been done better. And one of the things that we pay attention to is whether or not the correct medication was used or not. And sometimes it's really obvious, like if someone had a febrile reaction and they're treated with an antihistamine, that just doesn't make sense. Or vice versa. Someone's having an allergic reaction and they got acetaminophen for that, or paracetamol. So we do flag events, and if we think that there was a problem with how the patient got treated, because we don't know that the clinician's going to read the report, sometimes we just cut and paste the report and send an email and say, hey, do you want to talk about this? But in a way that's friendly. So I mean, I try closing the loop is really difficult. It's like if a tree falls in the forest, does anybody hear? We upload all kinds of narrative remarks, we interpret all of these reaction events, but how often do the staff actually read the report that was just mounted on their case? And so if we think it's one of these things that shouldn't be missed, we can't always tell if the individual is signed off. Now, some of this is up to the design of the EMR, like some EMRs, or some people have a relationship with the patient where they have to get notified every time a result comes in, and it's like the in-basket in Epic. But not all EMRs are structured that way. So if you know that your EMR doesn't have a way of sensing whether or not a report has been viewed, then I think you have to go old school and cut and paste an email sometimes. I mean, that's what we did with our old version EMR last year before we went to Epic. Not that I'm advertising for Epic, because it is a hard system. I have no conflict of interest with this corporation.
Let's not get into that now. It's all challenges. No, but thank you, Christine. And one last question. I think we are nearing the end of the webinar as well. Joe, just in your patient then, you mentioned that the patient did not have any response or limited response to eculizumab, but seemed to respond to tocilizumab. Now, is there any way that you can actually predict when you're in that hot seat managing a patient? Are there any predictors towards which agent you actually go in with first, and then how can you say the patient is going to respond to one over the other?
Really good question, that. I think, I mean, as sort of Christine just alluded to, I think when you throw everything at them, it is difficult to say conclusively which treatment worked. But I think with that case, we were quite confident that once we gave the tocilizumab, we saw the, in front of our eyes, the clinical improvement. And we've had another case we've used tocilizumab on recently. One of our registrars has just published our two cases, and we've put sort of a little algorithm on to suggest when to use eculizumab versus tocilizumab. And nobody really knows, but sort of those cases that we see with the macrophage activation features and the systemic inflammation perhaps would benefit more from tocilizumab. But again, it's not based on a hell of a lot of evidence because there isn't very much of it.
Okay. Now, thank you, Joe. And over to Barbie to actually then provide the closing remarks. And I think we will also have a poll as well. Over to you, Barbie. And thanks again to all the speakers for great, engaging presentations.
So thank you. I'm going to echo Shruti's remarks. Thank you so much to our presenters. This was a fantastic and very educational program. We'll have these materials available to you after the meeting, and just go to the IHN website. And thank you to our attendees, and we look forward to presenting another program to you. And please save the date for our in-person meeting, April 11th and 12th, 2024. Thank you very much. Bye-bye.
And before you leave, if you can all fill the poll, please, that should take less than a minute to actually then complete. But thanks again to all. We will just leave this link for a couple more minutes until people finish, and then we can sign off. Thank you.